Hi, everyone. I'm Ricky Thackram, consultant chest physician from UCH. Thank you for inviting me to talk about RDI, which stands for Red Dichromatic Imaging. We're going to talk about this today. So just before I start, a show of hands, how many people here do therapeutic bronchoscopy, debulking tumors, laser, coagulation? Show of hands? No one? One. Lovely. So this is something I really want to talk to you about, which I've been using quite a lot recently. So this is UCH. We're a major thoracic centre in London, and we do a lot of therapeutic bronchoscopy. So let's talk about red dichromatic imaging. So this, as well, anyone here who's doing therapeutic bronchoscopy, you'll know you'll get a little bit of bleeding in the airway. And we have lots of tools in our bag, don't we? So we have cold saline, we have some topical adrenaline, we have tranexamic acid. Sometimes we may use electrocautery or laser to coagulate, and sometimes we may use a balloon blocker. So I want you to consider this as almost like a tool that's in your sort of interventional bronchoscopy bag that you can pull out and use whenever you need. And there are a couple of areas that I think where this really holds its own. And that is one in the prevention of bleeding, and the second of identifying bleeding and then treating it when we see it. So just to summarize what red dichromatic imaging is. Now, normally in our white light bronchoscope, we have all the wavelengths of light coming through. And essentially with RDI, the blue and ultraviolet light wavelengths are removed. So what we have are the red, amber, and less of the green. And then through a specific filter, it's really filtered down to 3 specific wavelengths. When it hits the mucosa, what you get back is this sort of amberish color. But we'll see why, and I'll talk about how it shows you these blood vessels in a lot more clarity than any other white light imaging. So I've got a few cases. I'm just going to run through them, and we can then have some questions at the end to discuss. So first is about bleeding prevention. Now, the first picture here on the left is white light bronchoscopy. And you can see what we're seeing here is the white light is going onto the mucosal surface. We're getting a picture back. But when we switch to the RDI, what we see is the green light will be reflected back at a quite shallow level. The amber and red wavelengths will penetrate much more deeper into the mucosa and then will be reflected back. Now, what we see is where there's a big concentration of hemoglobin, i.e. a blood vessel, or a deep bronchial artery like here, is that a lot more of the red will be reflected back and some of the amber wavelength will be absorbed by the blood. So we see a much, much darker red image. Now, look, we know we're not going to biopsy anywhere in this area, but if you saw something like this, you'd want to avoid doing a biopsy in that area because you know that's going to create bleeding. So just to consolidate that, what we have is the green light coming in is really not affected too much by the mucosa, but the red and amber are really affected when there's a deep blood vessel or a real concentration of hemoglobin. So here you can see the amber light is attenuated a little bit and it's absorbed by blood, and you get much more red light back compared to the amber. So where there's a blood vessel, you'll really, really see that blood vessel coming into clarity. So this was a 45-year-old patient we did about 6 months ago, and she had an obstructed right main bronchus, which is what we're looking at here. And you can see it looks sort of very angry, almost it's going to start bleeding even if you look at it the wrong way. But when you switch the RDI on, you can see the clarity of the deeper blood vessels. And you can see how actually using this, you might want to target your biopsies in a very, very specific part of the tumor. So then we're not going to encounter as much bleeding. Now, in this patient, we went on to debulk and laser ablate the tumor. And so we restored patency to the right main bronchus. The other place where the RDI really came into its own is this picture is at the end of the procedure. There's a lot of surface blood. You're still not sure whether there's bleeding or not. But what the RDI does, it subtracts all that surface blood, as you can see in that picture. And that makes it much, much more easier to be sure and confident that actually at the end of the procedure, there's no active bleeding. We can stop here and that's the procedure done. So this is again to reinforce what we've just seen there in that last picture. So where we have dilute blood sitting on the surface, that's going to reflect back the red and amber light as usual. But where there's a big concentration of bleeding, you'll get lots of the red light back and less of the amber light. And as a result, what we'll see is an identifying area of active bleeding, which you can see just there. So I'm going to go through a few patient cases. We're going to start with something straightforward and then work our way up to something more blood pressure raising. Okay, so this is a patient of mine who had a congenital tracheal stenosis, had a repair in his childhood, and then invariably all these patients end up with some sort of stainless steel stent in their airways, and you'll see some of the remnants of that here. He has multiple problems, so he has granulation tissue, and then he has multi-level stenoses as we go down his trachea. And so he very frequently requires a procedure just to remove the granulation tissue because it usually grows enough to block the airway. On this occasion, it wasn't actually as bad as I thought it would be. So what I do is I have a look examine it first in white light and then switch to the RDI. The RDI you can see is reflecting back lots of the sort of yellow amber color, but no deep reds and no deeper red colors anywhere. And so to me, it says actually there isn't any deep vessels there. We're probably not going to encounter as much bleeding as I would expect. The rest of the assessment involves just looking at the rest of the airway. So what I use here is a cryoprobe. And I just put the cryoprobe through the working channel of the bronchoscope and freeze this little bit of granulation tissue off and remove it. I'm switching between the RDI and the white light on this occasion just to show you the sort of differences in what you would see. And you can see with the RDI, there's just that little bit more clarity. Now, straight away I go in with the RDI, you can see where the bleeding is coming from. And you switch to the white light, and actually that's not as clear. But what it allows me to do is the RDI showed me straight away that the bleeding's coming from there. So I can put my coagulation probe straight through the working channel of the bronchoscope. And you can see once it's subtracted all that surface blood, it becomes a lot easier to see. And so all it then requires is a very, very short burst of electric energy there. And we can coagulate the sort of bleeding area, as you can see there. And you can see if you had the white light on, you still wouldn't be sure because there's a lot of surface blood still there. So you can see with that, the example of using the RDI there, how much easier and much more clarity you have. And actually it also allows you to be a little bit less stressed and more relaxed during the bronchoscopy. So that was after sort of doing a balloon dilatation as well. Okay, next case. So this is a 45-year-old man who presented with a blocked left main bronchus. In this case, we approached it with a rigid bronchoscopy. And again, the aim was to restore patency to the left main bronchus. So we started with a procedure by removing all this tumor using cryo. Now, what I'm doing here is we're switching between the RDI to make sure there is no active bleeding. And as soon as you switch to the RDI, you can see that the surface blood is taken away and there isn't any active bleeding or any brisk bleeding coming from there. So actually that gives you confidence and gives me confidence to carry on debulking and debulking the tumor here. So again, here you can see in the white light, there is surface blood there. You're not quite sure, if there is still active bleeding, but you switch to the RDI and you can tell that actually there's no active bleeding here. I'm good to carry on to debulk. Now, for those of you that do this, you know that this can take a little while. So it took 1 or 2 minutes. And after this, we got to a position where we restored patency to the airway. Now, look, there's a lot of blood here, a lot of surface blood, but you switch to the RDI, and actually, there isn't much active bleeding, probably just that one area at the top there. And that was easily coagulated. And it just sort of helped us there. And we left a stent in because, as you could see, there was a lot of extrinsic compression. Okay, so we're into postgraduate bronchoscopy now. So this is a 60-year-old man who came in with fevers and night sweats. He had on his CT a blocked right main bronchus, and then this sort of band of atelectasis that comes all the way down. And he was a never smoker. He'd had some antibiotics. The ED had done a CT scan, which you can see there. And then we'd arranged for him to have a bronchoscopy. This is what the endobronchial appearances look like. So blocked right middle lobe bronchus. And does anyone guess what this is? Sorry? Cherry red looks like a carcinoid tumor, and you switch to the RDI, and you have these really, really deep vessels here, and actually you just look at this the wrong way, and it just started bleeding. So here we go. So this was the bronchoscopy. Now, the others I've edited a bit more. So this one is a little bit more raw. So you'll just sort of see how it goes. And I wanted to leave it like this because I wanted, this is, I guess, the reality of what we do. So we're going to take some biopsies and also debulk this tumor to restore the patency to the airway. So here we go. So we find a nice place. CO2 or nitrous goes down that cryoprobe, and we take a good chunk of biopsy. Now, for those that do this, you know that as soon as you've taken this biopsy and you come out, you have no idea what's going on in the airway, and there's any amount of bleeding that you're going to encounter as you wash that little bit of biopsy off and then take your time to get back in there, because you do have to remove the biopsy before you can get back into the airway and have a look. So you go in and there's bleeding, and actually there's a lot of bleeding, and it's very, very brisk, as you can see. But this is where the RDI for me really came into its own. So I switched to the RDI, and all of a sudden, actually, I can really, really focus on what's bleeding, just there. Blood pressure still raised, heart rate still a bit high. Mine's not the patient's. We put the electrocautery probe through the working channel. Deliver a little bit of thermal energy. Still feeling calm. Now, switch back to the white light. You can see it's not as good a view as you would want it to be. A little bit of cold. So switch back to the RDI and a little bit of cold saline, because actually I want to just be sure that the bleeding's completely stopped. But I'm pretty confident already. But all of a sudden I can relax because you can see there's no active bleeding anymore. It's all controlled. There's a little bit of a ooze, but it's all controlled. So that's RDI. So I want you to see it as sort of a tool that you have in your interventional bronchoscopy toolbox that you can take out and use in adjunct with other treatments and other therapies, not just for diagnosis, not just for preventing bleeding, but actually you can switch it on to remove that surface blood to allow you to treat areas that are bleeding. Now, I mean, this is completely anecdotal and this is personal to me, but actually for me, it reduces my stress levels seeing a screen that's a little bit yellow and amber compared to seeing a screen that's completely red and full of blood. So, for me, it reduces my stress when we're doing these sort of procedures. And that's everything I have to say about RDI.